afternoon. So the topic given is optimizing treatment for LUTO, investigating the impact of early intervention. So when we talk of LUTO, one of the most fundamental things that come to me is how am I going to diagnose it? And only when I have the proper diagnosis I can plan proper treatment. And any management of LUTO, we always do it in conjunction with the pediatric urologist. And let's go to the normal fetal bladder. The longitudinal bladder diameter less than 7 millimeters is between 10 and 14 weeks. So between 7 and 14 millimeters. And the size increases with gestational age. And we know that we now have Z-scores of the bladder size for the differentiation of that between post-urethral valves and urethral atresia. This is actually a very good study which shows the bladder is 6 millimeters at 15 weeks to 40 millimeters at 35 weeks, and this is normal. By looking at the Z-scores, it helps to identify LUTO caused by PUV and other subtypes. Then we go to fetal urine production, because after all, why we are seeing the bladder is to see whether the kidneys are functioning and the baby is able to survive because of that. Now, LICAR is an index of functioning kidneys, and it does not predict the quality of urine or the long-term renal function. We only know the baby is passing urine by looking at the LICAR. But the presence of LICAR is extremely important for lung growth. So if you look at the production of urine at 20 weeks, it's at 4.2 ml per hour. At 40 weeks, it's almost 52 ml per hour. It means more than 10 times. So in the first trimester, when do we call as megacystis? Bladder diameter between 7 and 15 millimeters is generally thought to be more associated with chromosomal abnormalities, and when the bladder diameter is more than 15 millimeters, we think obstruction. But irrespective of whatever be the bladder size, we must rule out aneuploidy and other associated abnormalities. Here is a large bladder diameter, which turned out to be urethral atresia, and both we call it as megacystis, but urethral atresia and post-urethral valves are extremely difficult to differentiate from. Now let's go to the second trimester, and if you see a big bladder, should we call it as lower urinary tract obstruction? Most common is post-urethral valves. There's a very wide spectrum of prenatal presentation. Other less common differential diagnosis we give is anterurethral valves, urethral atresia, urethral agenesis, and also a presacral mass which is compressing. Other etiologies for large bladder include Bartter syndrome and also the recipient twin transfusion syndrome. And all big bladders are not lower urinary tract obstruction, we need to know that. So the diagnosis of LUTO has been proposed. One of them is if you do the second trimester, gestational age in weeks -5, and third trimester, gestational age in weeks -3 is sort of a rule of thumb to say the bladder is big. And no emptying of the bladder over 40 minutes. You keep scanning the patient, bladder is not becoming small in size, and there is no standardized cutoff which has been shown. Now, there are many factors for diagnosis of LUTO. One is, of course, male fetal sex, which has got the highest sensitivity, with a large bladder, of course. Keyhole sign is only 50% sensitivity. Echogenic kidneys, oligo or hydramnios, referral less than 28 weeks, hydronephrosis, and also severe megacystis. So we can also look at the bladder shape. In prune belly syndrome, we have a bladder which is quite elongated, and in post-urethral valves, you can have an elongated bladder with a dilated post-urethra. In urethral atresia, you get a more circular shape of the bladder because of the obstruction and high pressure within the bladder. And of course, I'm going to show you a few different kinds of presentation which could be there. Distended bladder keyhole appearance is the most common method that you see, and male fetus immediately call it as PUV. But let's look at another presentation here. She comes at 32 weeks, unilateral hydronephrosis, left side dilated ureter and distended bladder. When you go to 34 weeks, bilateral dilated ureter, distended bladder with a keyhole appearance. So presenting as unilateral hydronephron nephrosis evolving in 2 weeks. Then you look at the third presentation. At 20 weeks, bladder was absolutely normal. At 29 weeks, you suddenly see bilateral hydronephrosis and a huge bladder, but there's still lots of liquor in this patient. At 31 weeks, there's megacystis and huge dilatation. At 33 weeks, suddenly there is a bladder rupture and there's also a perinephric urinoma. So this is what we call as the natural history of obstruction. Anything can happen during the pregnancy. The bladder can get distended at any point. So the question of early intervention is only for those cases which present early. Now here's a patient at 17 weeks, bladder was normal. At 21 weeks, the bladder was distended, but there was no hydronephrosis. Then both kidneys are normal. At 29 weeks, again kidneys are normal, but the bladder is enormously distended with good liquor. And 33 weeks, you can see megacystis with keyhole, and suddenly the upper tract starts dilating. So, do I call it as a posturethral valve with only a bladder distension without hydronephrosis is a big question. So, prominent bladder with incomplete emptying evolving in the third trimester. Now, but the other thing is, when you look at the kidneys and you look at cystic changes in the kidneys in the presence of obstruction, and these, once you see small cysts in the cortex, then we definitely know that these kidneys have become non-functional. There's a 35-year-old, 26 weeks, bilateral hydronephrosis, keyhole appearance, and the baby is passing urine very nicely. You can see fetal maturation happening. There's good amount of liquor. Now, does this baby actually require an intervention? Even though the bladder is so much distended and so much hydronephrosis, this baby is actually passing urine. And this turned out to be plum belly syndrome, and it's not a posturethral valve. Now, can ultrasound prognosticate? Now, our entire focus of treating LUTO is for prognostication. By looking at appearance of the kidneys, bladder wall thickness, amniotic fluid volume, and fetal urinary biomarkers. Poor predictors of poor renal function are increased parenchymal echogenicity, subcortical cysts, and oligohydramnios. So that brings us to the question of importance of amniotic fluid assessment. As a marker, we know that anything less than 5 amniotic fluid index less than 5 is severe oligo, but usually for the third trimester. In the second trimester, the maximal vertical pool of less than 2 centimeters is better. And though amniotic fluid volume is a poor measure of renal function, early mid-gestation oligo carries a 95% mortality rate, and this must be understood. Now let's go to urine sampling and see how far urine biomarkers help us. We can do urine sampling when you see a distended bladder, when the sodium more than 100, osmolality more than 210, beta 2 microglobulin more than 6, and cystatin C1 C greater than 1. Usually done 2 taps, 5 to 7 in interval of 5 to 7 days. Some people say you can do it after 48 hours. And fetal serum beta 2 microglobulin in predicting postnatal renal function seems to have a slightly better sensitivity, but you can't be going and sampling, doing fetal blood sampling every time. But it's supposed to be better than urine. But we did our own study many years ago, and we did histology of the kidneys, and we looked at kidneys between posturethral valves and PUJ obstruction, and we found babies with PUJ obstruction had less number of glomeruli per square micron area, and they had grade 2 interstitial fibrosis, which was much more significant than those with PUJ. And all cases of oligohydramnios had grade 2 interstitial fibrosis, which means oligohydramnios is present, then this baby has got very poor renal function. Now, people have also tried to do antenatal staging of urinary tract obstruction, like severe, moderate, and mild, based on the bladder volumes and also the amniotic fluid volume. And the survival, overall survival of fetus in relation to severity of UTO. The more severe the LUTO, the poorer the survival as expected. But what about the management plan? Ruano has brought out, published this thing about staging and also the management plan. And they said you could do, if the fetal urinary trace is favorable, amniotic fluid volume is normal, normal kidneys are bilateral hydro, then you don't need to do any intervention. But when the kidneys are hyperechogenic, there's oligo or anhydramnios, the prognosis is undetermined, they may be candidates for intervention. When there's hyperechogenic kidneys, cysts or dysplasia, urinary electrolytes are unfavorable, that it contains poor prognosis, but they could be candidates for fetal intervention, mainly for fetal survival and not for renal function. And when there is oligo or anhydramnios and dysplasia and urinary electrolytes are unfavorable, then these you consider termination of pregnancy. Now, the LUTO trial told us many years ago, whatever you do, if you are doing shunting, it is mainly for survival of the fetus and not for long-term renal function. What is our protocol for LUTO? Intervention is not considered in anhydramnios at any gestational age unless the parents insist. Fetuses with severe associated anomalies are excluded. Fetal karyotype is obtained between the first and second times 2 weeks apart, and a detailed renal scan is done, and only those with deteriorating parameters in the second and early third trimester are counseled for intervention. So the burning questions: if I intervene, will restoration of amniotic fluid volume reverse the effect of LUTO, avoid ventilation at birth, and intervention before 26 weeks of gestational age? Will it create reasonable renal chemistry, completely avoid the need for renal replacement therapy? Because these are all the questions which the parents ask. Can the need for renal replacement therapy be postponed to the second decade of life? So, of course, when we do the procedure, the vesicoamniotic shunting, which is the most common procedure which is done, we have seen the thoracoamniotic shunting, so it's more or less the same technique which we use, using the double pigtail shunt. And this was the case with more than 22 years after the shunting. The creatinine is 1.1, the baby is doing well. But this baby at the time of shunting did have some amount of liquor. Other complications like migration in 40%, reshunting in 30 to 40%, and premature rupture of membranes. And here the shunt got dislodged into the peritoneal cavity. It became a vesicoperitoneal shunt. And there are other issues in shunting. There is no bladder recycling. The baby forgets, the bladder forgets how to expand and contract, and prolonged postnatal recovery time is known. There are various types of shunts available. This also has been discussed, so I won't go through that. It's exactly the same, but the more recent one is called the vortex shunt, which has a valve inside, and this allows for bladder recycling. So the question now is early shunting better, and which shunt is better? So this study looked at vesicoamniotic shunting before 17 weeks, and they used the Harrison shunt and also the Somatex shunt, and they showed that there was out of 24 cases, 12 cases pregnancies went beyond 27 weeks, out of which 5 had oligohydramnios, a normal amniotic fluid volume. Out of the 5 you had neonatal death and also severe renal impairment. So oligohydramnios again corresponded to renal impairment. Normal amniotic fluid, the baby had normal renal function. Whereas with the Somatex shunt, again it was a similar appearance, oligohydramnios in 11 and normal amniotic fluid in 17, and most of them had normal renal function. So now let's go a little bit further and say, can we do it in the first trimester? So this vesicoamniotic shunt done prior to 16 weeks, they said results in improved preservation of renal function in surviving fetuses with isolated lower renal tract obstruction. There are higher rates of normal renal function in survivors. Before completion of 16 weeks, this goal could be achieved in about 80% of surviving fetuses, and beyond 16 weeks, normal fetal renal function was observed in less than 40% of the survivors. So between the shunt, not much of a difference. Now fetal cystoscopy is the new paradigm. We do fetal cystoscopy by between 16 and 18 weeks. We do laser fenestration in utero using a 10 to 20 watt laser. You can actually go and fulgurate the valve, and this is almost like creating what we do postnatally. And the postnatal cystoscopy, showed that we have done the fulguration at the correct well, and then a full fulguration was done afterwards. So this baby had a redo fulguration at 6 months and now doing well. So I'll summarize by saying, first trimester megacystis, rule out aneuploidy and obstruction. Second trimester big bladder, query LUTO, query other etiologies. Antenatal presentation is highly varied. The presence of liquor indicates functioning kidney but not indicative of postnatal renal function. Severe oligohydramnios, lung hypoplasia, renal dysplasia, urinary biomarkers do not have much of a role. So in severe oligo, no need to go and do the investigation. Option for therapy, fetal shunting, fetal cystoscopy. More data required for effectiveness of early intervention in less than 16 weeks. So case selection for shunting. Oligo, too late. Normal amniotic fluid, too early. Reducing amniotic fluid on serial scans may be one of the indicators you might want to do. Therapy may not improve renal function, but may help in better survival. Randomized controlled trials are not feasible in this situation. Fetal cystoscopy may emerge as a better option, but needs more expertise. Thank you very much.